welcome to, I'm Shelley Cohen-Conrad from representing our team from the Center to Advance Interprofessional Education and Practice. And today we're welcoming an amazing panel of folks to talk about treatment prevention of wound care in non-stigmatizing harm reduction approaches for people who use drugs. And we are excited about presenting it, and we have a less amount of time. We're going to be with it together for just under an hour, so I'm going to move this right to Kina to introduce our panel.
Great. Thanks a lot, Shelley, and nice to see everyone here. I'm Kina Thakrar. I'm an infectious disease and addiction medicine physician at Maine Health. And right now I'm the PI for a SAMHSA-funded harm reduction grant. Love working with students and scholarly projects. I really appreciate everyone being here. And I think maybe we can just tag each other. Zoe, you're first there, so I'll tag you.
Sure. Hi, I'm Zoe Brokus. I use she, her pronouns. And I'm the co-director of the Church of Safe Injection. We're a Maine CDC certified syringe service program with our main location in Lewiston. I'll pass it over to Marian.
Hey everyone, I am Marian Anderson. I use they, them pronouns. Also co-director of the Church of Safe Injection. I've been with this organization for some time now. Started out boots on the ground with just like a couple of us and have grown exponentially. Happy to be here. Thanks.
All right. Hannah, last but not least.
Hi, I'm Hannah Kazel. I'm one of the addiction fellows at Maine Medical Center. I just graduated family medicine residency out in California in July. I'm happy to be here learning from everybody.
And just to provide some context for this training, we have received some funding from SAMHSA, as I mentioned, for a harm reduction grant called Project Dharma, distribution of harm reduction access in rural Maine areas. This is a collaborative and multidisciplinary approach, that we're taking between syringe services programs like Church of Safe Injection, where Zoe and Marian are, and two other syringe service programs in the area. And we're really excited to be able to do these harm reduction trainings in collaboration with UNE. I just wanted to acknowledge some of our community partners who are no longer with us, but Jesse and Carrie, who are both really integral in the grant application process. And really a lot of the goals of the grant are their vision. We have many goals. I'm not going to list them all in the interest of time, but one of the goals is, specifically doing this interprofessional harm reduction trainings, in addition to sort of expanding capacity of the syringe service programs, linking people to care, testing for HIV, hepatitis, and also getting on the wound care supplies that we'll talk about in a little bit. So next slide. And here are conflicts of interest. Nothing that's super relevant for this talk, however. Next slide. And here are the learning objectives. I won't read, word for word, but you can see here. So we're going to review harm reduction-based preventive medicine and wound care for people who use drugs. We had previously reviewed harm reduction in the first training, but definitely a brief overview here. And we'll also learn about harm reduction across different professions, learn and get familiar with how to use non-stigmatizing language. And then really the focus will be reviewing wound care principles and the nuances of xylazine, which we'll talk about in a little bit if you are not familiar with xylazine. And finally, just understanding, best practices in working with people who use drugs. Okay, and here we have the results of the poll. Very exciting. So in terms of experiences treating wound care, that's actually quite impressive. So 57% of folks have had some experience, 43% not yet. That's okay. I as a student, also even as a fellow, we did not get much training in wound care. I've been learning from my nursing colleagues and really syringe service programs. So that's why we're doing this training too. Thank you for taking the poll.
Great. Thanks, Kina. So this is a pretty standard definition of harm reduction that some people have probably seen if you're familiar with the concept. We're at an interesting time here in the state of Maine where for years, harm reduction was not really recognized within the work of substance use, whether that was substance use prevention or treatment and recovery services. And syringe service programs were hardly funded if they were funded at all. And we've seen a huge shift, which has been welcome, but it is also interesting to kind of start to see the work that we've been doing for so long kind of standardized into deliverables in a way, that we haven't seen before. And so that has shown up in a couple of different ways. Wound care has been a huge part of that, really integrating wound care into the work that we're all doing. Safe sharps disposal, vaccinations for hepatitis A and B, and really, while this is a really great standard definition of harm reduction, I encourage everyone. I'm going to put a link in the chat if I can find it quickly, of a really beautiful definition of harm reduction that really speaks to the community aspect of it. And that reminder that for those of us who do this work, harm reduction isn't just when we're on the clock, right? It's like practicing harm reduction with each other, showing up for each other when things get hard. That's the real work. And that can be really challenging. So I'll put that link in the chat at some point and sort of encourage you all to read it. Next slide. So our organization, we are in our second official year of being certified through the Maine CDC. We got certified in January of 2021. Prior to that, we were sort of known as a bit of a rogue organization. We were founded by one man who really just started handing out supplies out of the back of his car up here in Lewiston and in Portland and up to Bangor. And he passed away in 2020. And then, the organization has just continued on. The person who took over from Jesse, our founder, unfortunately passed away in May of 2022. And we've just continued to try to keep the work going and keep Jesse's legacy moving forward. And so we're really proud of these numbers. These numbers continue to grow each year. 325,000 syringes distributed means that's also pretty much the same amount of used syringes that were collected and properly disposed of. So that's really important when we think of that broader community public health impact. And over 6,000 referrals, that really has been quite a feat. Our program has grown significantly in this past year. And we have a whole program of peer navigators who work directly in the community with people who are using drugs, ensuring that they're connected to our services here at Church of Safe Injection and connecting them to whatever other resources they might be interested in. We really focus on the importance of allowing individuals to engage in our services and make requests for other services when they want to and what they want. So really not pushing any sort of agenda when it comes to treatment or recovery resources or anything. A lot of the people that we serve here in Lewiston are unhoused. And so there's a lot of acute, immediate need. And wound care is a huge part of that. And so getting our team trained and comfortable with wrapping wounds, bringing in wound care nurses, and then the work that we're doing through the Dharma Initiative has been really critical in helping get people connected to medical care, because some of these wounds we can manage quite easily in the office. Others, really need antibiotics or sometimes surgical procedures. And so really essential that we have those great connections with our medical community. Thank you, Marian. This slide we like to use and remind people, especially anyone who is engaging in the community and working with people who use drugs, that reminder that sometimes we will walk into a room and make an assumption about someone's use because of how they're presenting or because of other things going on in their lives. I can guarantee that when you are unhoused, a lot of things can look chaotic, and sometimes using drugs is maybe the one thing that is soothing some of that chaos. And so it's always really important to not assume that we know what people's use looks like. I mean, Keena's the one who taught me this, right? We always ask, and that is an incredible privilege. And so building that foundation of trust first before we start asking really intimate personal questions to people about their use is really important. So thinking about what are those ways that you can help create that foundation of trust, build a relationship, help people feel comfortable. A lot of the folks we serve have had really harmful experiences in the hospital or with medical providers. And so just knowing that, I think, is really important, and recognizing it. And sometimes even just naming it is enough for people to feel validated and seen. And that's how we can make those changes and do better with the information that we have. And I just always have to kind of give a shout out to Dan. I don't know if anyone else knows him besides those of us who do harm reduction work, but Dan Big really single-handedly brought naloxone to places in the country where naloxone was not yet available. And so I can say with absolute certainty that the first naloxone that was handed out in the streets of Maine came from a duffel bag that came from Chicago. And so Dan is one of our real founders of harm reduction. He died 2 summers ago, and these were his rules. And I always remind our team whenever people get grumpy about meeting with students or taking on an intern, or like, oh, we don't have enough time for that. There's this is how we continue the work. This is how we continue to make harm reduction accessible and kind of take some of the stigma away from the work that we do every day. So I'll give everyone a minute to read through that. And Marion, I don't know if you have anything that you wanted to add. I kind of breezed through those slides quickly.
Yeah, Zoe, I think you got it all covered. I think the only thing that I would add is the importance of really being mindful of folks seeking healthcare, right? As a person who uses drugs, I would rather be on my deathbed than seek medical attention, just because of the ways in which I was treated previously. So yeah, really important to just be mindful of sort of how you're approaching a person who uses drugs. Language is important. Also, just really listening, I think, is the most important piece. Often, folks who use drugs get talked at, not talked to. So yeah, that's it. Thanks.
Great. Thanks, Zoe and Marion. And I really love that. It's something I just try to impart to the trainees I work with, is just like, listen, and that can open up a lot of doors, I think, for patients that we're seeing. As an ID doc, I'm always thinking about, how can we also, prevent some of these infectious complications? Because as Marion said, it takes a lot for someone to go to the hospital where, they may encounter stigma, with an infectious complication. So we always think about, how can we prevent these infections if someone's going to use drugs? How can we sort of optimize health and safety? And this is not an exhaustive list, but many of these are things that the Infectious Disease Society of America, IDSA, that we promote on a wide scale. So, and these are evidence-based strategies. Starting with the basic needs. That's last on the list, but maybe the most important. Housing. Addressing people's basic needs can then open the doors to them receiving the health services. We spent, a lot of the first training, talking about the work that syringe services programs do and that COSI does, safer use, promoting that with patients. And then on the prevention side, thinking about, offering vaccines. So as Zoe had mentioned, hepatitis A and B, Maine, I'm not sure if any you know this, but we have the highest rates of acute hepatitis B and C in the nation. Most of which we're attributing to drug use. And so, if we can prevent some of these things and offer people healthcare and vaccinations, we need to do it. And then obviously the other vaccines listed there, pneumococcal vaccinations, COVID-19, et cetera. Also offering folks testing for and screening for sexually transmitted infections. So far, Maine, we have a low prevalence of HIV, but certainly it's something we think about a lot. Many of our folks who are diagnosed, they're not diagnosed until they're much older and sort of late stages of HIV/AIDS. And so thinking about pre-exposure prophylaxis or PrEP for HIV prevention is super important, and something that, you know, folks working in primary care, pharmacy, et cetera, can, you know, prescribe PrEP. And this is really a great way to prevent HIV. Either, you know, it's a pill that someone takes every day, but there's also an injectable form. And I listed safe consumption sites on here. That's probably a whole talk in itself. We don't have time to talk about, but just I wanted to drop it in there to acknowledge that there's evidence-based strategies such as safe consumption sites where people can go to safely use drugs. They, you know, there's now a site in New York. There's sites all over the world. There's 0 overdoses in these sites, and, you know, hopefully at some point we'll see this in Maine. Next slide. So this is just a very brief overview, again, because we're going to be focusing mostly on wound care for this training, but just a brief overview of infection and overdose prevention, you know, things that you can offer in the healthcare setting. So again, going through safe injection and safer use techniques. If you know, came to the first training, we kind of went through some different techniques. I'm sure Zoe and Marion would be happy to weigh in if folks have questions about that. Again, and as I mentioned, STD evaluation, vaccines. As Zoe mentioned, many of the folks that they're seeing at COSI, for example, are unhoused. And so screening for tuberculosis, latent TB is really important. PrEP, as I had mentioned, to prevent HIV, linking people to care. That's something that we're working on with COSI, actually, is folks who are diagnosed with Hep C and are too, you know, for many reasons, face barriers to coming to a brick and mortar clinic. You know, we're trying to figure out ways, how do we get this person, you know, hepatitis C treatments in a way that they feel comfortable. Obviously, prescribing naloxone is one very easy way to do this. There is naloxone over the counter, but it's expensive. And then, you know, if patients are ready for treatments, just making sure that we offer very low barrier treatments such as buprenorphine, methadone, et cetera, if and when people are ready. Next slide. And at this point, I'll turn it over to Hannah, and where we'll focus the next couple slides on wound care.
Thanks, Kina. So we're going to shift gears and talk about wound care a little bit here. I am by no means an expert, and I want to acknowledge that patients are really experts in their wound care, and we should be learning from them, along with like folks who work at SSPs and in outreach. Those are the experts in wound care that we can learn from. And then furthermore, as already cited, like in the United States, right, nurses historically have pioneered and championed wound care work, especially in establishing relationships with unhoused communities that historically did not access medical care or have access to medical care because of many barriers cited over and over again from our facilitators here. But wound care clinicians now really do include a range of specialties, from nurses to podiatrists to infectious disease doctors to vascular surgeons, plastic surgeons, so many people. So wound care, this is really kind of a bird's eye view today, but generally for people who use drugs, it takes place outside of the healthcare setting. So that's where people feel safe, they feel comfortable, they feel heard. And it's really important for you to remember as a clinician, because it's going to guide how you counsel your patients, and understanding access to supplies and water and what have you. Additionally, when you're considering the environment with folks, sometimes remember that wounds can have odors, sometimes they can be disfiguring. And so asking for consent before you proceed and before you provide any sort of care is important as well. And then remember, our patients are our teachers. We have so much to learn. It's really our job to support them, to step in when we might think that someone might necessitate a higher level of care, and partnering with them to understand and educate ourselves, you know, even as clinicians, right? When is that absolutely, you know, indicated? How can we partner with you to make it a safe kind of encounter in a trauma-informed way? In terms of tenets for patients and clinicians alike, the basic tenets, if we're starting from scratch, right, you want to keep the wound covered with a durable dressing, moisture balance, you need the Goldilocks of moisture, not too wet, not too dry. There's the cleaning techniques. You're going to bring lots of gloves with you. It's not sterile, right? But you don't want to be moving like contaminated bacteria from the wound to other parts of the body or to the dressing you're about to put on top. Marking borders. Patients really know how to do this. And nutrition, hydration, right? Know your resources, know where their food banks are. You need nutrition, vitamins, and water to heal, right? And then in terms of safe injection practices, I think this was reviewed in the last session, but a lot of people operate under the belief that injecting into the same wound in the peri-wound area is actually protecting the rest of their tissue and body from damage. And in reality, clinically, can make it harder for that wound to heal, can propagate and further risk spreading infection and damage like clots or other kind of serious events to happen. And so we need to learn how to counsel as clinicians, other places, how to counsel patients on safe injection, where to inject and things like that. So again, wound care is like very medically nuanced. This is the bird's eye view, and clinicians spend years mastering these skills. And again, patients are experts, so you have so much to learn from them. This is a photo from the New York Times piece that was published last year. It's out of the Kensington neighborhood in Philadelphia, where xylazine hit hard and first, and a lot of our data and information and practices came out of the Department of Health and out of from people with lived experience. In terms of the environment, so we need a proper healing environment in addition to like the surrounding environment that I just discussed, but it needs to be well vascularized. You got to remove necrosis, all that dead tissue. Moisture, so majority of medicine's history, we thought things had to be dry and open to the air. In reality, that's not true. In the 1960s, there was a pig study that actually showed moist wounds heal better, and that was replicated finally in humans and standard now. Treat infection. Infected wounds do not heal, and all wounds are colonized. That doesn't mean they're all infected and need antibiotics, right? Review your clean technique both for yourself and for patients. Bring lots of gloves. Dressings are supportive. They do not heal the wound in and of themselves. They can actually cause harm if they're not chosen intentionally. Pain medical considerations. For people who use drugs, this is no different. People need pain medications. Wound care is painful. People might show up to you with pre-medication on board. That's okay, right? And then when you're thinking about complications, maybe there's systemic or spreading infection, you're worried that somebody might need to go to the hospital. Again, when's it medically necessary? Partner with your patients, understand their point of view and perspective, and the risks and benefits of self-care versus, progressing to specialty care, and acknowledging the trauma that our patients have experienced time and time again at the hands of our medical system, which, I operate in on a day-to-day basis as a physician. So wound care in practice, I'm going to try to go through this quickly, but you want to identify the underlying cause, right? So if it's infected, do you need oral antibiotics? If you've got peripheral neuropathy, wounds also can't heal if there's a lot of sugar running through our blood, right? And so maybe you need more glycemic control. Peripheral artery disease, you need blood supply to heal. You need a vascular surgeon, right? That's not a safe thing for us to be treating in the field really alone. And wound assessments, this is important both for you, the people who come after you, and it's standardized in terms of measurements and documentation, but you need to look at the location, pain, infection, tunneling. This is if there's little, sinus tracts underneath the tissue, or if the wound bed is separating from the edge, called undermining. You're going to review frequency of dressing changes, the peri-wound health, what drainage is looking like. For cleansing, if the wound is not infected or not necrotic, you can really irrigate or kind of flush with tap water and saline. Tap water, is just as good as saline in the studies. And then if it's infected or you're worried about necrosis, you should really use something like Dakins or Vosh, which is sodium hypochlorite. It's an antiseptic. For debridement, this is multiple modalities listed. There are surgical, enzymatic, biologic, or things like maggot or larval therapy. This is prescribed, right? This isn't someone that comes in with it. Not prescribed. Topicals, these are things like MediHoney, right? It's an antimicrobial agent, anti-inflammatory. We're not reaching for topical antibiotics empirically. We don't want to create resistant bacteria. You want to, at the end of the day, promote that moist wound healing environment, protect your peri-wound 4 centimeters around that wound edge, so your entire wound can heal. Packing and dressing, these serve to control your exudate, prevent bacterial overgrowth through practices like packing the dead space. And remember, longitudinality, continuity care, relationships are way more important than any fancy, expensive dressing that you can just give one time, right? It's about forming relationships and trust with your patients. Just briefly, these are common wounds that you might encounter in the field. On the left, you have an abscess that hasn't drained yet. The middle, you have a cellulitis, is an infection of the skin, the top and the middle layer there, and on the right is a complicated ulcer. Xylazine. So some of you may have heard of this, but it's a large animal tranquilizer, approved for veterinarian use only. It's alpha-2 agonist, works like clonidine for humans at least, and it's heavily sedating. It's cheap and it's being cut in the illicit drug supply in the United States. Majority of what we know about xylazine, about wound care associated with xylazine, is from people with lived experience and patients in communities who are like boots on the ground. And this is a flyer from Philadelphia on the left side there, Department of Health. They did a lot of harm reduction work like we cited earlier. They've got the Never Use Alone app on there, the Brave app. If you just Google ODT, overdose detection technology, there's some evidence for use of those different modalities. And then most recently in Maine showed that fentanyl and xylazine, the combination from 2023, contributed to 42 overdose fatalities, which is 8% of the overdose deaths in the state.
Thank
I think
you.
we're going to move to breakout. Yeah.
Yeah. Thank you, everyone. And thank you, Zoe Marion, for responding to questions in the chat. Keep them coming. So we're going to go to a breakout session now so that you can share your thoughts. We're going to have facilitators in the breakout sessions, and we ask you to have your video on so that you can see each other and talk with each other about this really important and also very delicate subject. So this is the case. It's Stacy, a 35-year-old woman who uses syringe services programs regularly. She usually injects fentanyl in her upper extremities, but is eventually hospitalized for lower extremity and severe skin and soft tissue infection, very much like what we've seen on the screen. So here are the questions. They'll be in the chat. Kristen will get them in the chat for us. What are your initial thoughts about Stacy and her healthcare needs? What have you learned from what we've heard today about wound care in your curriculum, but also from today? And also how might you work with her to prevent future complications and safe use? So we're going to be divided into our breakout sessions, and we'll see you on the other side. Always meet the patient where they are. Don't talk at them, but talk with them. Thank you, Sarah. So true. So true. The importance of listening. From Kristen, it's important to ask the patient what she would like to get from this when they visit. So again, this theme of, you know, our patients, the people we work with are our teachers, and we are there to listen to have effective healthcare. I learn about a lot about how you, whoops, I lost that. I learned a lot about how you can see things from their perspective and get to know the patient before jumping to conclusions. Really important. In our group, we talked about the importance of understanding the continuum. That slide and that conversation was so incredibly helpful. Lovely chat about oral health and about the importance of all of us, if we're oral health providers, if we're pharmacists, if we're docs, if we're nurses, the importance of everyone having this knowledge to share. I'm looking at the other facilitators. Anyone else want to add something from your group, a takeaway before we move on? Because we just have a little bit of time left. Ina?
Oh, I think those were all great points.
Oh.
No, go ahead. Go ahead.
Hi. So yeah, our group really delved into the harm reduction principles that could be aligned in that clinical atmosphere when working with a patient, how we probe the right questions, how we offer the patient the chance to share what they know about their wound or their use, etc. We talked about navigating how we might send that patient back out into their community, wherever they're living, whether they be homeless, whether they be in some other type of environment, and what wound care might look like when they leave. That was a big one. How to ask your patient if they're capable of caring for their wound when they leave, things of that nature, and how to offer that respect and the right tools and messaging as well. Do they leave with a printout of what we've just explained? Do we also offer links so that they have a couple of different avenues to choose from based on what their tools are and their accessibility to that information when they leave, or ability to hang on to that information? Things like that, amongst other things. But
Really, really incredible. And Kina, do you wanted to add something? Thank you, Christina.
No, actually, some folks from my group put our take home points, I think, in the chat and summarized it quite nicely. Lauren was saying, we talked a lot about social determinants of health, considering their greater environment, I think, as was just discussed, and working with them to kind of minimize, future repeat wounds, as Colby mentioned.
Yeah. And Donna, adding again, knowing what the resources are, developing trust. I think the developing trust, being aware of socioeconomics, what the patient wants, and how critically important that is. I think we're going to you, Kina.
Great. Yeah, and we didn't touch base on this a little in our little group, so hopefully this will be beneficial to others. One thing I just wanted to discuss briefly was this concept of drug checking. I'm not sure if folks are familiar with this, but it's worth noting that potentially our case, Stacy, may have had a wound related to xylazine, which is a contaminant in the supply, and so what we're trying to do here in Maine through our SAMHSA grant, Project Dharma, is initiating a drug checking program so that folks can really feel empowered to learn what is in the drug supply and what they're using to really inform safer use, basically. And so this may be anything from using a fentanyl test strip or xylazine test strip to what's called FTIR analysis, where these are handheld machines that are going to be at a couple of our syringe services programs, including COSI, to detect substances. It only takes about 10 minutes. This is like super exciting. And then the gold standard is really on the right there. Is GCMS, or mass spectrometry, which we're partnering with Colby College and their chemistry students, their undergrad students actually, to do a lot of the testing for the drug supply. So you may be hearing a little bit more about this in the news, but also if you have clients, patients, community members who could benefit from this service, feel free to reach out to us. This is going to be run really through the syringe services programs. And why do we do this? I guess is maybe I should have led with this slide, but I think our whole goal is really just to get this information to the people who need it most, which is really people who are using drugs. And we hope that by providing this service, this might be a way to engage them in harm reduction services and in turn, other healthcare services. And really, it took a lot of advocacy work to make this happen. We actually had to pass legislation here in Maine, but we're really hopeful that this will help to reduce overdoses and sort of infectious complications, and will hopefully be of value to our patients. Okay, well, I think that's sort of the end here of our slides. So I think just as a reminder, if anyone needs CME, there is the code. And you can also go to Maine Health's website.
So I want to thank our panel. I wish we could, clap out loud, everybody, and thank you so much for a very enlightening session. And you can get in touch with folks if you have more questions. Our next knowledge exchange will be on the effects of pharmaceutical waste on human and planetary health, and that is on February 28th. And we hope to see a lot of you there. So thank you so much, and we'd love your feedback. Make sure you fill out your attendance and give us some feedback, good, the bad, and the not so great, and or the excellent. And thank you so much for coming.